What to do when you have a premolar with an unrestorable fracture. My name is Dr. Ed Sherrard. I'm the owner of Springfield Dental, and today we're doing a case study video about a premolar which had an unrestorable vertical fracture and one way to resolve that problem and how I fixed that problem. So, if we start with the before picture, here we have the tooth with the fracture. So it was one of those scenarios which reinforced my belief in managing teeth with fracture lines visible. That's because this patient had a conversation with me about, you have a tooth with a restoration, but I can see fracture lines visible. They said, let's keep an eye on it. And also, this tooth you'll see in a sec was root filled, so even more sort of alarm bells of that tooth could crack. The patient decided to leave it and take their chances. And lo and behold, a couple of years later, they came in, this tooth feels a bit funny, have a look, and the two sides are moving independently. And when you see the sides moving independently and you check it out a bit further, often it's game over, and this fracture ran way down the middle, and it just, in my book, just wasn't properly restorable. So we talked about options. There's a close-up, you can see the crack running through there. And we talked about options, and we talked about my advice to remove the tooth and replace it, the classic replacement options of denture, bridge, or implant. But the patient was about to go away and didn't want to do anything significant before going away and coming back. So we did a sort of compromised repair to try and get through that time. It was, I don't know, it was like a week. So what we did was we did a direct onlay. We chopped the height down by about 30–40% and strapped the tooth together with composite. And because it was non-vital, there wasn't a nerve that was jarring every time he bit on it. So we took it right out of occlusion and strapped it together with composite, which worked as a sort of get out of jail situation to get us through to the next week for when we went onto the definitive treatment. Here's another view of the tooth before. So what we decided to do was an immediate implant. So nobody really likes the idea of a denture, even a temporary denture, although sometimes it's needed. Maryland bridge, obviously, like a resin bonded bridge would have been an option. But all things considered, this patient wanted to go down the route of an implant. And because of the way things looked here, it looked like an immediate implant was suitable. So the reason why we went for that was there wasn't a clear sign of a big infection above the tooth. If there's loads of infection present, then personally I wouldn't do an immediate implant because there's too high a risk of failure in my eyes. And yeah, that's the main thing. And then also we took a CT scan, and the bone shape, the bone availability for an immediate implant in this area looked good. So if we carry on through, we have the extraction site. So we remove the tooth, and we have the site ready. We cleaned the site, so we curette the site to clean the bone all around the socket. And then you'll see there's an image later. Generally in a site like this, the palatal bone is where you have the availability to put the implant. So we prepared the osteotomy into the socket, but palatally. And fortunately, we could get enough fixation of the implant, so enough torque where it was sort of screwed in tight enough that it could take the loading of the tooth, the temporary crown, immediately on top. So we got the implant in place. That is the top of the implant there, placed quite far below the soft tissue, but also below the bone level either side, to sort of anticipate that the bone level might drop a bit. And obviously, if you are not somebody who places implants much or regularly or at all, you might think quite rightly, an implant is not the same size as the tooth that came out, and surely there'll be a gap, and there is a gap. And in implants, you call it jumping the gap. And what you tend to jump the gap with to fill the rest of the sort of socket hole is some sort of bone graft. And in this situation, we used Mineros, which is a good bone graft source. And then here's another view. So we filled around there, cleaned up a few of those bits after this picture. And then what we moved on to is a temporary crown. So you have a cylinder, like a temporary cylinder, which screws into the implant, and then you can build up a crown on top. So I tend to build the base up with some flowable composite, then build the rest of the tooth roughly, then take it off, polish it. So it's a good sort of rudimentary shape. It's never going to be as good as a definitive crown, but so you have a clean, nice shape that will hold the soft tissue position, create a contact with the teeth either side. There's a bit of an unfortunate concavity there, which didn't matter hugely in the long run. And then, yeah, here's a CT scan. So that bone up here is exactly what you're looking for if you're looking to do an immediate implant, or it's the sort of thing that I'm looking for, because you've got height past the apex and also palatal. So we would curette all around there, preserve the buccal bone, and the implant goes in about here. There's a radiograph of the implant and the start of the sort of temporary crown, which we then built up to the full height. And yeah, so a bit of a bumpy shape, but it did the job. There was a contact point, it held the soft tissues in the right position, and it healed well over the following months. And I think, yeah, that's the last picture I've got. So that has now integrated, and it now has the definitive crown on top. So what we did was leave it for I left it for about 3 months, because, you know, the temporary crown is working. There's no particular rush while you're waiting for it to integrate, in my opinion. So left it to integrate, then unscrew the temporary crown, put a scan post in the top, took an iTero scan, got the provisional crown scanned as well for a reference for the lab for a general shape, so they know what the soft tissue looks like underneath there, and then got the definitive restoration made, and that's now screwed in and it's gone well. And I forgot to take a picture of the definitive restoration, which I'll do next time I review the implant. But yeah, hopefully you found this helpful. Maybe interesting if you're looking into doing implants, or if you already do some implants. Immediate implants is kind of a slightly separate thing to placing implants in a delayed way. There's different factors to consider, but I don't do it every time by any means. But in a scenario like this, in a visible area where the bone was good, it seemed like a good approach. So if you have any questions about dental implants, other topics, anything you'd find an interesting video on, a case study, let us know. And thank you for watching, and see you in the next video.